nutrient interactions and how we assess them. So, adverse drug and food interactions, or food and drug interactions, can prevent the therapeutic effect of the medicine or drug taken. They can make a side effect worse. They can cause an entirely new side effect. And so this is the Academy of Nutrition and Dietetics position statement from 2010. And I'm not going to read all of this, but you can. But I want to highlight this part here. The association promotes a team approach and encourages active collaboration among registered dietitians and other health team members. The health team member you would probably collaborate with the most for a drug would be a pharmacist. So it's important that you, as the RDN, are talking with the pharmacist to make sure that you're giving the patient the best information possible. Your role as an RDN is to advocate for, organize, and implement medical nutrition therapy. It's also your role to develop a nutrition prescription for medical nutrition therapy based on the individualized needs on energy, macronutrient content, vitamin and mineral content, fluid content, and importantly, the influence of potential medications. So the RD may implement medical nutrition therapy to prevent diseases, to prevent nutrient medication interactions, to prevent secondary complications, or as the sole therapy. So we talk a lot about disease prevention, a lot about cardiovascular disease, type 2 diabetes. And I think that these nutrient medication interactions and secondary complications aren't what people generally think of when they think of the RDN. But medical nutrition therapy should provide a synergistic effect with pharmacotherapy. Think about type 2 diabetes. How important the medication is with diet. And this should be consistently updated based on the most recent diagnosis or to re-educate. Other examples would be things like thyroid disease. Will have a medication and a diet component. Often a lot of GI issues. So medication and diet need to work together. The role of the pharmacist is to be the expert on medications. And they're responsible for sharing information on potential medication nutrient interactions and educating individuals about how to safely and effectively take the medications. And the pharmacist manipulates medication dosages to optimize the therapeutic effect or to avoid side effects. And the pharmacist can work most effectively when a RD's expertise in foods has been combined with the pharmacist's own expertise in medications. And really, the key point here is the pharmacist, RD, and entire care team need to be a collaborative, interdisciplinary for comprehensive care and to improve healthcare quality and safety. So, something of note is the individual differences in drug metabolism. Medical nutrition therapy needs to be tailored to each individual. So, things to consider are age. Often, as we age, glomerular filtration rates decrease. So, we don't eliminate drugs as fast. So, they'll stay in the system longer. Additionally, we see loss of muscle mass with age and an increase in adipose tissue. Nutritional status can also affect how we metabolize drugs. So 3 months of poor dietary intake can lead to low thiamine levels. but thiamine needs will be increased if someone's on diuretics. And this can lead to an anemia due to congestive heart failure treatment. So there's many ways that food and drugs can interact. The dosage of the drug, the person's sex, the size and weight of the person, the overall state of their health, time of day the drug is taken, all will affect drug metabolism. And patients at risk for drug nutrient interactions are often older patients, patients with chronic diseases, patients that are on a long-term drug therapy, or patients who are on a multiple drug therapy. And these aren't exclusive to each other. These are actually all interrelated. Older patients tend to be patients with chronic diseases on long-term drug therapy using multiple drugs. Not always, but they tend to. Patients who are malnourished, patients with increased nutritional needs, or patients receiving enteral nutrition. So first, let's talk about macronutrient food-drug interactions. So a food itself can affect drug absorption in the GI tract. It can alter gastric pH. It can change secretion of enzymes. It can change gastrointestinal motility. So think about the difference in motility when you drink a hot drink. That generally increases gastrointestinal motility. Transit time. Think fiber. And this can result in a change of the rate of absorption or the extent of drug absorption, or both. So, for example, azithromycin, which is an antibiotic, absorption is decreased when it's taken with food. In fact, it results in a 43% reduction in bioavailability. And again, this is an antibiotic. So we don't want to reduce its bioavailability because then we're increasing risk of developing an antibiotic-resistant bacteria. Sustained release theophylline products, when taken with high-fat foods, can cause a sudden release or dose dumping of the theophylline. This is because it is lipophilic. Resulting in increased theophylline concentrations and possible toxicity. And children tend to be more susceptible to this than adults. And one reason for this is the higher metabolic rate in children. Theophylline is a medication used for COPD or asthma. It is a bronchodilator. So, some mechanisms on how food can influence drug bioavailability. If the gastrointestinal contents have a higher viscosity, this can reduce the rate of dissolution in the GI contents, and the absorbing surface may be reduced by increasing viscosity. So again, how do we alter viscosity? Primarily with a soluble fiber. Alterations in the rate of gastric emptying. So hot meals containing a high amount of fat tend to decrease the gastric emptying rate, thereby delaying onset of action. And the stimulation of gastrointestinal secretions. Food stimulates secretions from the GI tract, resulting in an influence, or the resulting changes can influence drug stability and absorption rate. We have chemical hydrolysis and enzymatic metabolism, which can reduce drug bioavailability. And biosalts and surface active agents can increase the absorption of drugs by increasing the rate of their dissolution. So this stimulation of gastrointestinal secretions can increase or decrease bioavailability. We also can have competitive inhibition of a drug by food components. So some drugs have a structural similarity to a nutrient and may also be absorbed by the same mechanism. So there can be a competitive inhibition to the drug absorption in the presence of nutrients. An example of that is levodopa, which is a treatment for Parkinson's disease. Dopamine synthesis is related to tyrosine. So a high protein diet, high in tyrosine, could influence levodopa. And then there can be complexation of drugs with dietary components. So tetracyclines can form insoluble, non-absorbable complexes with calcium ions, with calcium ions, when they're present. Further, this is why we don't recommend taking tetracyclines. These are antibiotics. With milk. And in fact, tetracycline is one of the antibiotics used for the treatment of acne. Food with high iron content can also reduce bioavailability due to complexation. And this is observed only when the drugs form an irreversible or unabsorbable complex. Other mechanisms can also be blood flow to the liver. So blood flow to the GI tract and liver increases shortly after a meal. This increased blood flow to the liver will increase the rate at which drugs are presented to the liver. And recall that the liver is going to be a filter for drugs. So the metabolism of some drugs are sensitive to their rate of presentation to the liver. The greater the rate of presentation of such drugs to the liver, the larger the fraction of drugs that may escape first pass metabolism. Oh, and this is just, this diagram shows competitive inhibition of a drug by nutrients. So this is an example of the iron or calcium. So some examples of food-drug interactions that accelerate the absorption of drugs. Something like propranolol, which I always, this is the worst lecture because I struggle saying the names of drugs. Propranolol is a beta blocker, sometimes also used for anxiety. Food may reduce first pass metabolism and extraction. It is recommended to take this with food. Similarly, spirulactone and grisofluven. Some examples of drug-food interactions that delay the absorption of drugs. So acetaminophen, which is Tylenol. High pectin foods can act as an absorbent and a protectant. So it's recommended to take Tylenol on an empty stomach if other contraindications don't exist. Similarly, like we talked about, we see levodopa. And again, it is the fact that dopamine also is made from tyrosine, so tyrosine can compete with its absorption. Digoxin is, it is a blood pressure medication. So also high fiber pectin foods can also influence it. This is a nice table just with a summary of some of the food-drug interactions. I won't go through all of these, but uh, this is a good resource to have. It's it's not your job to know every medication and potential interaction, but if you see one of these medications on someone's chart, it would be good to check with the pharmacist or look this up yourself to make sure that you aren't giving them information that may interfere with their drug metabolism. So, like I mentioned, we can reduce absorption with dietary minerals. They can outcompete for active sites. The drug alendronate, alendronate uh, is impaired by basically everything. This is a osteoporosis drug. And it should be taken with plain water and nothing else. And nothing should be consumed for at least 30 minutes. Oops, I'm always writing over my own stuff. But sometimes food may be useful in reducing the side effect of a drug. For example, ibuprofen, which is also known as Advil, can be particularly hard on the stomach. So, unlike Tylenol, it's recommended that you take ibuprofen with food. So, take Advil with food. This doesn't reduce the bioavailability, but it helps protect your stomach. And this is because ibuprofen can irritate the gastrointestinal tract. So, if we want to enhance bioavailability, sometimes we need an acidic environment for drugs like ketoconazole, which is used for fungal infections. The absorption of glycofluven is increased by the fat in a meal. And fenofibrate, mebendencinol, isotretinoin, all of these other ones are better absorbed with food. Similarly, lovastatin also should be taken with food to enhance gastrointestinal absorption. And this is one you might see because, as its name suggests, it is a statin. So it is used for the treatment of high cholesterol. So food and minerals and vitamins can increase or decrease the efficacy of a drug. So vitamin K and warfarin is an example. Warfarin is a blood thinner. Vitamin K is a clotting factor. And of course, alcoholic beverages increase central nervous system depressant effects and can interact with a variety of painkillers, psych drugs, antihistamines, all sorts of things. So really shouldn't be taking alcohol and drugs at the same time. So we have drugs. These are highly controlled. You can't just go anywhere and buy a drug that isn't illicit usually. But foods can vary in nutrient content due to a variety of factors. And in fact, with drugs, every pill you take should be exactly the same as all the other pills. But with foods, the content of nutrition can vary between foods. But both of them have an oral administration and use the GI tract to be absorbed. They then go to the liver, and then to circulation, and then they do whatever action in the body. They go back to the liver for excretion, and some are excreted through the kidney. So actually, Advil is broken down in the kidney. Tylenol is broken down in the liver. So some important pharmacokinetic areas are sublingual, under the tongue, the stomach, and GI tract. It can also depend on the distribution of fluid in the body, adipose tissue, and muscle, the person's metabolism. So also the ability for elimination. So that can be kidney and liver health. And factors influencing medication elimination may increase the likelihood for medication-medication interaction. So if your kidney or liver is damaged, you may increase the likelihood of medication-medication interactions. So the primary action of food nutrients interfering with medications is via proteins important for absorption, distribution, and elimination. So polyphenols, commonly found in fruits, can inhibit or induce cytochrome P45 enzymes. These enzymes are important for the elimination or breakdown of many drugs. And this can result in acute or prolonged supplementation with polyphenols. So let's talk a little bit more about cytochrome P450 or 450. You'll also see these called CYP. So these are major enzymes involved in drug metabolism. They account for 75% of total drug metabolism. Mostly, CYPs deactivate drugs and facilitate excretion. Mostly. There are CYPs that can activate drugs. And CYPs form active compounds of, CYPs form the active compounds of the antiplatelet drug, clopidogrel, and the opiate codeine. So they mostly deactivate, but some do activate. So you may have been told this, or a family member has before. They start taking a medication, and the pharmacist is very specific that they cannot have any grapefruit juice. The reason for that is that grapefruit juice contains bergamottin of moderate potency, but enough to inhibit CYP3A4. And this can result in a fatal interaction with drugs like estomazole or terfendin. Ugh, these drug names absolutely kill me. And this is an antihistamine. And the effects of the grapefruit juice aren't just immediate. They can last for 3 to 7 days. Again, it depends on the person's metabolism. But the greatest effect is when the juice is taken an hour after administration of the drug. And noni fruit and pomegranate juice are similar, although they're less common in the US, so they often aren't told to not take them. And this is quite important because the CYP that grapefruit juice inhibits is responsible for half of all CYP drug metabolism. We also do run into issues with supplements. So valerian is a sedative and anti-anxiety. I saw them selling it at the herb shop downtown as a sleep aid. But this also can interfere with CYP3A4. So again, this is another big table. It shows drug class, major interactions, and then some minor interactions. So there are other inhibitors besides grapefruit juice with unknown potency. One is cannabidiol or CBD. CBD also can decrease clobazam metabolism, and clobazam is a anti-seizure drug. So definitely don't want to interfere with that. Milk thistle is another supplement, and we'll get into even more of these in the supplements. Niacin, so excess niacin. Ginkgo biloba. So ginkgo biloba is actually an antivitamin, and it interferes with pyridoxine phosphate. So think about which vitamin that is. And it can also interfere with anticoagulants such as warfarin. So I'm always amazed when people are taking ginkgo biloba because it not only is not proven to be good for you, it actively gets in the way of vitamins. And sesamin, which is from sesame seeds, is also used as a dietary reduction or a dietary supplement for fat reduction. So some things that can induce CYP3A4 are phenytoin, and this interacts with vitamin D. We'll get into St. John's wort a lot in the supplements. Basically, don't ever take St. John's wort. It interacts with almost everything. Antipsychotics, immunosuppressants, the digoxin that we already talked about, HIV drugs, cancer medications, warfarin, antidepressants, other heart-related medications. And it decreases the effectiveness of estrogen-based contraceptives. So I did see this being sold at the Herb House. In fact, they had like posters up about it. I didn't, but I was very tempted on asking them if they knew about all of these interactions. I highly doubt it. So again, you don't have to memorize these tables, but these tables are here to help you. So if someone is taking St. John's wort, one, just tell them to stop taking it, but do make sure that they're also not taking any of these drugs. So other CYP interactions,